Hey, everybody, and happy Thursday. It is time to thrive. And we are going to discuss today osmolarity because we have been talking about, sorry, I'm trying to share my screen here. We have been talking about IV fluid management this week, and we are continuing on with building your foundation. And all of this stuff is going to circle around and bite you in the butt for boards. So, fluid management, super important. We know that surgery causes a lot of shift. We got the ICF, the ECF, and all these compartments, right? We've got water, we've got electrolytes, we have all these things, and they're shifting and they're moving, and then we're losing blood with surgery. We're third spacing fluid. We're having third space losses, right? So there's all these things happening, and our patients, their electrolytes can be off. They can have kidney problems, heart problems, overhydrated, underhydrated. So we have to understand these basics and these foundation in order to build upon it and be really, really, really good nurse anesthetists. Okay. So let's dive on in. So first of all, osmolarity and osmolality both measure concentration. Okay. So the one that we're going to focus on is osmolarity, which is the number of osmoles per liter, which is a volume thing. Osmolality, I just wanted, because you guys probably see that word, I just want to clarify, it's the number of osmoles per kilogram. So it's more of a weight thing. Okay. So that's the difference between the two. The fluids and stuff and the plasma and everything we talk about is measured per liter volume osmolarity. Okay. And then we know that tonicity of our fluids, like hyper, hypo, iso, all that good stuff, we'll talk about in a second. That's comparing those, the LR, the albumin, the whatever, there's comparing that osmolarity to plasma osmolarity. And in essence, that tells us when I'm putting fluid into my patient's body, depending on what's going on with the patient, where is that fluid going to go? Or what is the osmotic force that is going to happen when I put a fluid into a patient? Okay, so that's why we care. And we know that overall osmosis, right? We learned that like basic chemistry a long time ago, is water moving from a high solute concentration to a low solute concentration. Because remember, all we are walking things of water. We got some blood in us as well, but we also have a bunch of solutes or things floating around, as in electrolytes, right? So that's all it is. Don't make this hard. Okay, so we can't talk about osmolarity without talking about sodium, because sodium actually determines the osmolarity of our plasma, and it is like the principal ECF cation. So our extracellular fluid is the principal cation that's in there, and it reflects our hydration status. Okay, I threw a couple other things in there. ADH primarily controls sodium concentration by increasing water absorption via the kidney. Aldosterone also increases sodium absorption through the kidney, and the renin-angiotensin system also increases sodium and water reabsorption. Okay, so we're not going to go into that. We'll talk about that another day, but you have to understand sodium, the role that sodium plays in osmolarity. Okay. So what do we do with this stuff? How do we apply all this stuff? Why do we even care? So first of all, we have to remember that our plasma osmolarity is about 300, okay? So when we give isotonic solutions, those are the ones that we're mostly going to be giving. So the LR, the plasmalite, the sodium chloride, that's what we're mostly going to be giving our patients, right? Because we want to expand their ECF volume, right? We want to give them volume as they're kind of losing stuff via surgery, their MPO status, et cetera, like that. But we have to be careful how much we give them, because it also dilutes coagulation factors, it dilutes albumin, and they potentially do dilute H&Hs and all that good stuff if they are already anemic. So Crystalloid is giving in a 3-to-1 ratio. So for every 3 mil, you give 3 mils of crystalloid for every 1 mil that's lost. So you give 3 mils of crystalloid for every 1 mil that's lost. So we do increase the risk of peripheral edema with that. So we do have to be careful, especially in certain surgeries when they're prone, when they are in steep T-berg. Obviously, if patients have any kidney or heart issues, we have to be careful how much crystalloid we give, right? Now, colloids, on the other hand, such as albumin, which albumin is actually isotonic because it's right around 300. So anything isotonic is going to be right around 300 osmolarity. Colloids, we can actually give 1-to-1. So we give 1 mil of colloid for every 1 mil loss. So we can actually give less, and they're actually really good about expanding plasma volume. So I have actually given albumin in acute situations where the patient's, end-stage renal disease, they're super hypotensive, hypotensive and I've got to get some volume on board. So I will actually, I will hang some albumin or push some albumin. Even if I have a patient crashing, if I don't have blood right away, if some freak thing happens, I grab a thing of albumin and give it. I also actually had a preceptor at one point that would inject like half a bottle of albumin into his crystalloid, into his LR, NS, whatever it was. And he would actually give that during prone cases, during steep T-Berg robotic cases, because it actually would help with hypotension and expand that plasma volume a little bit. So you don't need as much of that. However, there is a risk of hypocalcemia with colloids. There's a risk of kidney injury, and there's a risk of anaphylaxis. So stuff that you want to keep in mind, okay? So really quick, I know I try to be super quick, but talking about tonicity and stuff again. So remember, isotonic, our LR, our sodium chloride, the stuff that we're giving all the time, it's about 300 milliosmoles per liter. That's the osmolarity. It's similar to plasma, because plasma's osmolarity is 300, okay? When you give something that's hypotonic, so hypotonic, like 0.5% sodium chloride, that's going to have a lower than 300 osmolality, right? It's going to be decreased. It's hypo. And when you give 0.5% sodium chloride, it's going everywhere. Okay. It's like giving free water. Now, when you have a hypertonic, it has increased osmolarity. So it's going to be higher than plasma. It's going to be greater than 300 osmolarity. And that's what we give, like 3% sodium chloride that we give for hyponatremia, cerebral edema, and that's going to pull from your intracellular fluid to the extracellular fluid. Okay. So super brief. I hope that was helpful. I am excited for you guys to use this knowledge and be amazing. So have a great Thursday. I'm cheering you guys on always, and I will talk to you super soon. Bye.